You are now listening to Nailed It, the Orthopaedic Surgery Podcast.
But let's go ahead and take a look at this. And so, is this your main approach for any CMC work? This is kind of your main approach that you do. Is that correct?
Exactly. Yeah, I do a dorsal approach, whether I'm going to do an implant or a trapeziectomy or a neurectomy. I'm going to do it all through the same incision.
Okay. And what are your landmarks for marking out this incision?
So basically, if you extend the incision in your mind all the way up to the thumbnail, to kind of bisect the thumbnail at the 50-yard line, and then goes all the way down, that line to the radial styloid, and you just center it over the CMC joint. And you make it as long as you need to. Usually it's about 3 to 4 centimeters for an arthroplasty, 2 to 3 centimeters if you're doing a denervation.
Okay. And are you doing this under MAC and some local, or are they like completely out most of the time, or does it depend on the patient?
It depends. I've done it under everything. I've even done these under straight local. When you're doing the trapeziectomy under straight local or the implant under straight local, it's a lot to ask of the patient. I mean, you can get through the surgery, but they're kind of hurting in the recovery area. So for the implants, I usually do a regional block. If I'm doing a denervation, I'll do that under MAC with system local.
Okay. All right, cool. So I guess I'll click play here, and then you can kind of just walk us through a little bit about of what's happening here, and we can just go through that.
Sure. So the first thing you're going to look for is you want to find your EPB tendon. That's the lighthouse to the thumb. There's like a little sheath on top of it. And so at this point, the right there. Sensory branch of the radial nerve, we've identified and retracted that with the weedy on both sides. And now I'm opening up this sheath on top of the EPB. And if you stick on top of it, you can spread off both the branches of the sensory branch of the radial nerve and also the radial artery. I'm going to take it proximally and release it completely to the first compartment. And I release the first compartment on every one of these. You don't want to come back and have to do a de Quervain's on these patients later on. Plus, the more you mobilize the tendon, the safer it is. Just the tension on that tendon with a weedy, it can actually rupture the EPB during the course of a case.
Oh, wow. Okay.
Yeah,
so
you just fix it with a stitch, but you don't want it.
So first thing, again, so just to repeat, first thing we did is you went down and sized over the tendon sheath over the extensor pollicis brevis. You release a little of that proximally, and then you release it. Yeah, release it proximally, and the superficial branch of the radial nerve. That's superficial to everything. That's why you're using your scissors to kind of stay underneath that nerve, correct?
Correct. Yeah, you got to really watch out for that nerve. If you ding that nerve and get a neuroma, you're going to be in worse pain than they were from their arthritis. So you just really want to avoid that. And that's, in my practice, what I've seen revising people, the number one cause of failed CMC surgery is SBRN neuroma. It's not impingement. It's not whatever. It's not SCT arthritis. It's SBRN neuroma.
Okay. All right. And, okay, cool. So you see the little tendon, nice yellowish structure, and you use this whittlers to just, what are we doing? Are we just teasing? Are we just trying to?
Yeah. So now I'm trying to work. So first compartment is EPB and APL. So I got to show APL. APL terminates at the base of the thumb metacarpal. And so when I'm doing my implant arthroplasty and I'm sawing off the base of the metacarpal, I often end up disinserting this a fair degree. But here you can see I'm working on top of APL and kind of showing those fibers and releasing that. And you often will see some of the muscle fibers from the thenars over there, and you can just release those. That's fine. There's no penalty in doing that.
And our APL is this right here.
Exactly.
Correct? That's our APL. And then this up here is our EPB tendon right
Correct.
There. And you're just kind of just freeing up between there. And then our superficial branch of radial nerves is somewhere around over here, if I'm
100%.
If I'm not too mistaken here.
No, you're perfect. And so we want to work in between those two tendons. So, you release on top of EPB and APL, so you mobilize them. I'm going to pull EPB ulnarly or dorsally. And I'm going to pull APL volarly or radially. I'm going to kind of put that weedy back in there and keep working in that space. And that'll protect me from my sensory branch of the radial nerve and also the radial artery, which radial artery courses directly on top of the scaphoid. So it's a good way to find it. If you are doing a trapeziectomy, if you had to move the radial artery to get to the bone, stop. You're about to pull out the wrong bone. Don't do that. And it goes dorsal to the trapezium to form that feeder in, passing it through the first dorsal interosseous and princeps pollicis of the thumb.
So let's see here. So this is us you're just, again, developing that interval between the APL and the EPB. And then this is kind of more of the capsule right underneath these two tendons.
Right. And so there's like a little areolar layer with the feeders from the radial artery that go down to the joint capsule and more stout. So now I'm putting in the weedy underneath those tendons. And so you want to stay right on top of that. In doing this also, I've taken the nerve branches. So that I've basically done the denervation right here. So branches from SBRN to the joint we took off, and branches from palmar cutaneous branch and median nerve we took off to get down there. Now, by working in this plane, this will help me prevent injury to the radial artery. And I do a capsulectomy. I do sort of an L-shaped capsulectomy, which I just drew out there with the scissors, where I come across the base of the metacarpal and then down on the radial side of the metacarpal, and I flap that back up. That keeps me from, if I come across the capsule a little bit more proximally, I can take out the radial artery to the trapezium, which if I maintain the trapezium is a problem.
And you do an L-shaped capsulotomy kind of like that.
Reversed. So
50-50 chance here.
Yeah. Well, no, believe me, you can spin it a couple other ways. So I do the one limb transverse across the base of the metacarpal. A little bit more distal. And then
then kind of something.
One more. So I basically, I'm telling you,
man,
things are. That's why surgery is hard. I mean, they have this stuff be very confusing pretty easily. So where that little red dot was, make your transverse limb right across there, kind of near the end of that weedy. Yeah, there you go, right there. Transverse across the base of the metacarpal.
There we go. So we got something here. Yeah.
Yeah.
So
and then come proximal along APL.
There it is. There we go. Third time's a charm.
No, well, I'm telling you, you can rotate it 4 different ways. And that's my approach, whether I'm going to do an implant or trapeziectomy. It gives me a really nice capsular flap. I can flap that back down and close the joint up pretty nicely.
Okay. Well, let's continue on here. So now you're actually about to do it.
Still yakking about something. I think I'm taking this areolar tissue off the top.
Okay.
Again, to make sure that I don't that radial artery can sneak up on you as you're coming along the dorsal side of that metacarpal. So if you don't elevate that off, you could definitely get that radial artery, which isn't the end of the world. The hand isn't going to fall off, but you just want to avoid it.
You just rather not.
Exactly. And so now I'm making that transverse cut on the metacarpal. And then now I'm coming down inside of APL.
All right. So this is right where APL used to be.
Exactly.
Behind it. Right.
Exactly. And then I'm going to kind
of teasing that off
exactly.
Of the bone itself.
Exactly. And I drop my knife real flat, real parallel to the bone so I can get all the periosteum up off of it. So you have a nice layer to repair down at the end.
Okay. I like it. Well, so this is just kind of finishing to raise the rest of our capsule. And then now we're down to our first CMC joint. And then, we're down to do whatever procedure that, that we need to do, whether it be, implant or, hemiarthroplasty versus trapeziectomy or whatever, tendon ligament reconstruction that, we can all kind of access that with this approach.
Exactly. Yeah. The structures to watch out for: sensory branch of the radial nerve, radial artery. If you watch out for those, everything else will be okay.
Yep. And just to repeat, one of the keys to not injure the radial artery was just raising those full flaps where we know the artery is going to be in it. And so we know we're coming straight off of the bone and that we're not going to, get into the wrong plane and accidentally nick the artery.
Exactly.
Well, again, Dr. Greer, I think this has been great. I really appreciate you taking the time out of your day to come on the podcast and talk some hand and we'll go through and share one of your surgical videos and kind of the approach and spending time to break it down and go through these different approaches and these different how many ways can I draw a capsulectomy in the wrong direction.
Well, the thing is, any of those would have worked. They just weren't the way I did it, right. but all of those would have gotten you there. It really wouldn't have mattered.
Right. Well, again, Dr. Gray, I really appreciate you coming on to the show. For those listening, please tune in and hit the subscribe button and go and leave us a review and let us know how much you enjoyed this episode, listening to it. And also, if you're on YouTube, I hope you like and subscribe to the channel and put a comment in the comment section. And please don't go too rough on me for drawing these capsulectomies the wrong way after you clearly described it the first way. But again, Dr. Gray, really appreciate it.
No, thank you so much. I'm really excited with what you guys are doing. It's fantastic.